Just let me know when you can see my screen. I'll just start the screen share. Okay, so I hope you all can see my screen now. I'm just going to make it full screen. So this is the season 4 of the Mumbai Pain Schools Pain Journal Club, and we are in the journal club number 73. Today we are going to discuss about MSK ultrasound, head-to-toe ultrasound guided interventions and Bursa injections. So I welcome the esteemed faculties, Dr. Navita Purohit, ma'am. Ma'am, welcome.
You.
Also welcome Dr. Aanchal. I just check and make her a co-host. Welcome Dr. Khushboo as well as Dr. Mahmoud, both of you. And just before we begin, I'll just go through the basic intro. So pain medicine world over, as we know, is got diverse issues and variable standards all across. And there are different learning requirements for different physicians, and as a result, there are different offerings. And money and time is a big constraint in understanding about this very difficult to understand subject. So Mumbai Pain School, as an initiative of Panisha Spine Wellness and Pain Relief Center, has embarked upon this mission to teach in this field, and we have mostly utilized the online platform like the Facebook, with the Instagram and other media where we've got good traction. And most of our courses are focused on online learning, on demand, both free and paid content. Most of our content is free. We also run some paid content. We have been conducting some webinars as well as live workshops in person, which are the hands-on workshops. And we are very fortunate to have been blessed with expert faculties from all over the world. It is said that the best teachers, they teach from the heart and not from the book. So we have all these expert faculty supporting us all through this time. Journal Club is nothing; it's just a club where instead of drinking and dancing, we are focusing on critical evaluation of recent academic literature, which is based on a defined subject. And we value attendee participation. So those of you who are attending online on Zoom as well as on other media, just feel free to ask any questions, and we'll be very happy to take them up and discuss. It is very tough to be regular. As I mentioned, each time that we see new joinees every week, and the old ones, they just skip a few weeks and come try to be regular. And of course, even Harrison had his own journal club where he used to critically evaluate academic literature. Um, and this was held twice a month. So, time and discipline is important. So, I request both the speakers to be concise, precise, and stick to their timelines. Healthy skepticism or praise is most welcome. This is a bit about me. I am a pain physician working in Mumbai. But today we have our faculties, Dr. Aanchal Sharma. She's done her MD anesthesia from PGI Chandigarh, and she's done a fellowship in pain medicine from Chicago. She's also board certified from American Board of Pain Medicine, and she's currently the head of department for pain and palliative care at BLK Max Hospital, New Delhi. Welcome, Dr. Aanchal.
Thank you.
We also have with us Dr. Navita Purohit, ma'am. She's MD, DNB, and CIPS and fellow of Indian Academy of Pain Medicine. She's specialist in pain medicine, palliative care. She's the first woman in India who's certified interventional pain sonologist from World Institute of Pain. She's done advanced training in pain management at Harvard School and various other places. She's trained for cancer pain and palliative care at Tata Memorial Hospital, and is a certified palliative care physician from Indian Association of Palliative Care. Her special interest is in ultrasound guided pain management, regenerative medicine, and platelet plasma. Welcome, ma'am.
Thank you. Thanks, Sidharth.
So, I now request both the speakers. I think one of you can start sharing your screen and we can go live. I think Dr. Mahmood, you are going first. I made you the co-host. You can unmute yourself and you can start sharing your screen as well as you can share your presentation. Let me know if there is any issues. I can help you out. Dr. Mahmood?
Yes,
Yeah.
sir. Yes, sir.
Yeah. Okay. I'll let you know when I can see your screen. Please put your CV slide so I can introduce you.
There is just a net connection error.
Is there any problem? Then we can go with
Just internet, no, it's net connection problem, weakness in internet.
We can tell.
You want me to start, sir?
Yes, sir.
Yeah. Okay, sure. Khushboo, you can start first. No problem.
Okay, fine, sir. Sir, I'm keeping my video off because there is some network issue
I
at my
understand.
side.
No problem.
Yeah.
Your voice is clear. That is all that matters.
Yeah. Okay, sir.
Good. Please start sharing your screen.
Yes, sir.
I can start right now, sir.
Yeah, I think this is Dr. Khushboo's this thing. So Dr. Mahmood will present after Dr. Khushboo. Okay.
That's fine. No problem.
Okay, sure. So Dr. Khushboo, can you make it full screen and we
Yes,
go
I'm making it.
fast? Yeah. By now, all of you should be expert. You should not spend time in. Good. So Dr. Khushboo Dubey has done her MD, PDCC, FIPM, NFPM, MBA. So we have a lot of different uh, qualifications. She's a lead consultant in Department of Pain Medicine and Palliative Care at Fortis, Banerghatta Road at Bangalore. She is also the consultant pain specialist at Max Onco Pain Clinic at Jayanagar, Bangalore. She's also consultant pain specialist at Samprada Onco Wellness Hospital again at JP Nagar, Bangalore. So over to you, Dr. Khushboo.
Sorry, sir. I just need to adjust this.
Just click the screen once and go behind.
Yeah.
Make it full screen first.
Yes, sir.
Yeah, no problem. Click the screen once and then use arrows. Okay.
Yes, sir.
Please start.
The topic of today's presentation is on ultrasonography guided common musculoskeletal interventions from head to toe, procedural tips for general radiologists. This is a clinical review article published in Korean Journal of Radiology in December 2021 by Ronald White, Michael Croft, Stephen Bird, and Matthew Sampson. The study was conducted in various departments of radiology at Adelaide, Australia. Introduction. The pictorial essay enhances understanding and confidence in image-guided musculoskeletal procedures, which boosts the acquisition skills of general radiologists and trainees. The study has methodological and clinical-oriented approach based on authors' experience and evidence-based practice, where the procedure is presented from rostral to caudal end. The study is accompanied by figures depicting procedural approach, injection site, and labeled ultrasound anatomy, serving as the bedside aid for the quality of healthcare in ultrasound guided imaging. Aims and objective. The study aims to equip radiologists and trainees with the skills needed for effective procedure execution and patient care by offering methodological and clinically oriented approach in ultrasound guided musculoskeletal imaging. The study focuses on authors' experience coupled with evidence-based practice literature, and the objective is to enhance understanding and confidence in performing image-guided musculoskeletal procedures. Results and discussion. The procedure following are the procedures covered in the study, starting from the cranial to the caudal end. Greater occipital nerve block. The greater occipital nerve block is derived from the posterior ramus of C2, which supplies the skin of the posterior scalp. The clinical prevalence is on the conditions like occipital neuralgia, cervicogenic headaches, and migraines. It is best performed at inferior obliquus capitis level, seen in the figure A. To locate the nerves, first the probe is positioned into a transverse direction at the base of the occiput to find the posterior arch of C1 identified by single spinous process. Eventually, the probe is move more inferiorly to locate the bifid C2 spinous process. Keeping the bifid C2 spinous process in the view, the probe is then moved to the lateral and oblique direction to locate the obliquus capitis muscles. In figure 2, we can see the location of greater occipital nerve, which is in between the inferior obliquus capitis and semispinalis capitis muscle. The complications of this procedures usually include pain, bleeding, dizziness, weakness, and numbness. Barbotage. It refers to repetitive injections and withdrawal of fluids. It is used to aspirate the fragment of calcium hydroxypeptide crystals in the shoulder. The deposition of these crystals in the shoulder can cause calcific tendinitis, which is most commonly affect the rotator cuff tendons, in which 80% of the involved tendon is supraspinatus, with 15% infraspinatus and 5% subscapularis. The figure A shows barbotage of single needle technique, and we can see in this figure the calcium deposits in the technique of the barbotage. The figure B shows the ultrasound image where needle tip can be seen in the arrow, which is positioned in the calcific material of the barbotage. The barbotage is explained with the double needle technique in this figure C, where 22 gauge needle and 18 gauge needle is being used. The saline is injected into the calcific deposits from a 10 ml of syringe via connecting the tube and 22 gauge needle, while simultaneously aspirating the calcium into the 20 ml syringe via 18 gauge needle. The steroid is to break the adhesions and to provide analgesia. The subacromial bursa is liberally injected with 10 to 15 ml of 1% xylocaine. The steroid injection into the subacromial bursa at the end of the procedure is used to prevent the bursitis. Shoulder hydrodilatation. This is a non-surgical approach to the treatment of adhesive capsulitis, also commonly known as frozen shoulder. It leads to loss of ability of to externally rotate the shoulder associated with the thickening of rotator interval capsule. The glenohumeral capsule contraction and thickening of glenohumeral ligaments is usually seen. The procedure aims to distend the shoulder capsule using the fluid volume. We can see the positioning in the lateral decubitus position for the shoulder injection. Figure B demonstrates the shoulder injection with lateral approach of needle, which passes deep to the posterior labrum. And ultrasound figure C shows the injection in the medial approach. The author's preference is basically low volume hydrodilatation with using the maximum volume to 5 to 10 ml. The complication seen is hemoarthrosis and septic arthritis. Suprascapular nerve block originates from the superior trunk of the brachial plexus, which contributes to C5 and C6 nerve root. At the suprascapular notch, the nerve can be located with an artery and the vein. We can see the positioning in the when patient with sitting position with the needle posteromedial approach. In figure B, the ultrasound image of the injection can be seen in the suprascapular notch. Injecting into suprascapular notch is associated with risk of pleural puncture if excessive accidental anterior needle advances occurs. Complication includes pneumothorax, nerve injury, infection, and bleeding. Subacromial bursa injection subacromial bursa is basically fluid-filled space located in inferior to the acromion process and superior to the supraspinatus. Bursitis lead to antolateral pain. The figure A demonstrate the posterior approach to avoid anterior subacromial or supraspinatus stereo, where the patient is positioned into a relaxed position in the sitting position, where the relaxed arm positioning allows the relaxation of deltoid muscle, thus reducing the pain and discomfort. The figure B demonstrates the ultrasound image of the steroid injection with needle shown in the arrow in the subacromial bursa. The complications include infection, bleeding, and recurrence of pain. Tendon injection elbow. Common flexor and tendon and extensor origin. The common flexor and extensor tendinosis are overuse injuries that correspond to flexor and extensor tendon origins, where the common extensor tendinosis is more frequent than common flexor tendinosis. It results from the repetitive microtrauma that causes through the excessive contraction of wrist extensors or flexors. The extensor carpi radialis brevis is most commonly affected extensor tendon, while pronator teres and flexor carpi radialis is more commonly involved in the flexors origin. In figure E here demonstrate the patients in the supine position with arm abducted and resting above the head, that is flexed, abducted, and supinated position, which allow the easy access to the common flexor origin. Figure B demonstrate the injecting of steroids and anesthetics along the tendon surface to help the strip neo vessels to reduce the pain of the tendinity. Here we can see the direction of the needle. The complications include infection, bleeding, tendon damage, and rupture. Wrist joint injection and arthrogram. Arthrography is the assessment of articular structure or visualization of distribution of therapeutic injection. The wrist arthrography is used to assess the triangular fibrocartilage complex and intrinsic ligaments. The positioning is basically patient lying down, patient hand in the prone in neutral wrist position with volar flexion or given over a pillow. The ultrasound image shows the needle inserted from the distal approach to the scaphoid to pass below the dorsal of the radius. The commonly used used for the articulation of scaphoid and radius. The complication includes joint pain, infection, hand swelling, and bleeding. Ganglion cyst aspiration. Ganglion cyst clinically present as soft tissue proximal to synovial joint. Most common soft tissue is a most common soft tissue swelling with hand and wrist, with 70% involvement in the dorsal wrist and 20% on the volar compartment. Generally, it is asymptomatic but may cause cosmetic concerns, paresthesia, pain, and weakness. Mostly self-resolving, but if not, aspiration is the management is a modality of management. The recurrence rate is very high. Here we can see the positioning of dorsal wrist in the ganglion injection, where a towel is given to help with the proper flexion of the wrist joint. The figure B demonstrate the image guided loosening of cyst contents with 3 to 5 ml of 1% of xylocaine with a 25 gauge needle. we usually inject 1% of the xylocaine under the needle with the same needle to allow the anesthesia time to work. By using 18 gauge needle and 10 ml syringe, we perforate and aspirate the cyst from the ganglion. And 1 ml of celestone is injected into the ganglion at the end of the procedure to reduce the inflammation after the procedure. Pulley release. The procedure is used to treat stenosing tenosynovitis, also called as trigger finger. The imbalance of flexor tendon and sheath with thickening of A1 pulley causing snapping and locking of finger. The concurrent steroid injection at the time of release will treat any coexisting tenosynovitis. The figure A shows the positioning of the hand with hyperextension of metacarpopharyngeal joint, which is created with help of small rolled up towel, and general pressure is applied to the patient on the fingers. The figure B shows the schematic representation of needle movement with needle withdrawn in the blue arrow direction while applying downward force of the syringe, which forces the needle tip in a palmar direction to cut the A1 pulley. The figure C demonstrate the 18 gauge needle direction deep into the A1 pulley prior to the release. The ultrasound features of trigger finger usually seen as hypoechoic thickening of A1 pulley, which with increased edema surrounding the tissue. With the arrow, we can see the direction of the needle and the thickening of A1 pulley. General complications include pain, infection, bleeding, and nerve injury. Hip joint injection. Hip pain can be intra-articular and or extra-articular caused due to any pathology related to lumbar spine or pelvic floor, bowel or bladder, or a reproductive organ, or it can be mixed. Intra-articular ultrasound guided steroid injection or PRP of hip joint can assist the management of osteoarthritis or femoroacetabular impingement. Usually 9 cm 22 gauge spinal needle is used to ensure the adequate needle length to reach the hip joint. Figure A demonstrates positioning with patient on supine direction and leg is and the foot is rotated. So there will be an internal rotation of the foot. The inferolateral approach basically helps to move the femoral vessels, move medially out of the path of the needle. The inferolateral approach also helps to avoid the femoral nerve. The ultrasound image depicts the position is confirmed by the needle tip beneath the labrum and micro bubbles in the joint. The inferior capsule is thickened and harder to penetrate as opposed by the thinner superior capsule, which is an added benefit aiming deep into the labrum. Point to be noted that the turning the needle at 180-degree clockwise and anti-clockwise will help the bevel bore through the tented capsule. Complications include infection, bleeding, neovascular injury, and tendon injury. Mechanical hydro-release of the sciatic nerve. Sciatic nerve arises from L4-S3 lumbosacral nerve root. After exiting the pelvis, the sciatic nerve courses antero-inferior to the piriformis, posterior to gemelli orbis, obturator internus and quadratus femoris. Sciatic nerve irritation can cause lumbar, gluteal, and thigh neuropathic pain, which is significant to impact the quality of life. Adhesions can form on sciatic nerve in response to muscle injury or chronic muscle stretching associated with gait disturbances. The figure shows sciatic nerve hydrodissection, which is under ultrasound. The use of 22 gauge needle from the sciatic nerve which form secondary to chronic hamstring or piriformis injury. Use of liquid pressure ahead of the needle to mechanically open the tissue planes is being used. The complication commonly includes bleeding, infection, nerve or tendon damage. Knee joint injection. The most common intra-articular knee injection includes corticosteroid to relieve osteoarthritis, juvenile idiopathic arthritis, gout, pseudogout, and rheumatoid arthritis. The figure shows the position within a mid flexion of the knee and lateral positioning of for the knee joint injection. The figure B aim in the trochlea of the cartilage with with a lateral approach with the knee in mid flexion direction. The needle placement can be seen with the arrow mark lateral to the trochlear level. The common complication include hemiarthrosis and septic arthritis. Paratenon stripping or non-insertional Achilles tendinosis. Achilles tendinosis is a degenerative condition that exhibits tendon thickening and neovascularization of ultrasound. Insertional tendinosis involve tendinopathy occurring along the 2 centimeter portion between the tendon and its insertion at the calcaneum. Non-insertional tendinosis relates to 2 to 6 centimeter segment proximal to the calcaneum. Adhesions formed between the paratenon and the Achilles tendon is through chronic inflammation. The paratenon stripping is a process of injecting saline into the tendon or paratenon's interspace to break up the adhesion. Figure A shows the positioning of the patient in the prone position. Medial or lateral approach can be used, placing the 22 gauge needle deep into the paratenon but not in the tendon substance. Ultrasound image shows the needle position at the deep paratenon for stripping, and a high volume injection can be started at 10 ml using the 10 ml volume of 1% xylocaine followed by 1 ml siliston and cold saline to a total volume of 40 to 60 ml. The complications include bleeding, infection, nerve injury, and chronic pain. Intermetatarsal bursa injection is found between phalangeal joints. Being dorsal to the digital nerve, its anatomical location accounts for symptomatology of intermetatarsal bursitis. Pain radiates from the toes, affecting the space known as metatarsalgia, exacerbated by weight-bearing, high heels, and narrow shoes. If left untreated, the bursa can calcify and fibrose the surrounding interdigital space. Figure A showing the positioning with the dorsal approach to intermetatarsal injection. The ultrasound image of intertarsal bursa in the third and fourth intermetatarsal space is seen with the micro bubbles observed in this ultrasound image. Key point to note, a dorsal needle approach with the ultrasound probe on plantar aspect of the foot is beneficial and is less painful, as there is potentially less skin flora on the dorsal aspect of the foot compared to that of the plantar aspect. The common complications include bleeding, infection, pain, and recurrence. Plantar fascia injection with nerve block. Plantar fasciitis is the pain of the pain at calcanean origin of plantar fascia. The most common cause of this is the most common cause of heel pain exacerbated by prolonged standing or running. Combined with the tibial nerve block, the discomfort of the procedures can be alleviated. If the injection is too inferior, the medial calcanean and lateral plantar nerves can be missed. The positions shown patient on lying down in a supine position with foot externally rotated. By blocking the tibial nerve at the level just above the medial malleolus with a 1% xylocaine with total volume of 5 to 10 ml can be injected. Figure B shows the injecting of steroid deep into the plantar fascia. Make sure the needle shouldn't be too superior because it might cause fat pad necrosis. Dry needling can also be performed for the same conditions. Common complications include infection, bleeding, fat pad necrosis, lateral plantar nerve injury. To conclude, the pictorial assay offers a systematic approach to ultrasound-guided musculoskeletal procedure for general radiologists and trainees. Procedure include brief revisions of definitions, indication, clinical pearls, and complication, enhancing user understanding. it combines authors' experience with evidence-based practices from the literature, ensuring clinical-oriented approach by emphasizing a structural methodology. It enhances procedural understanding and skill acquisition of radiologists and trainees seeking to master ultrasound-guided musculoskeletal intervention. Limitations. Limited referencing of guidelines, referencing relevant guidelines for each procedure would have further supported the clinical decision making. Lack of randomized control trials and comparative studies to evaluate the efficacy and safety of the described procedures. There is limited generalizability of the finding as experience and techniques may vary among different practitioners and settings. Potential bias as authors, personal experience influencing the recommendations provided. Absence of long-term follow-up data to assess the durability and recurrence rate of the interventions. There is insufficient discussion on potential contraindications or patient selection criteria for each procedure. There is lack of specific references and citations to support the information, which limits the ability to verify the accuracy of the information provided. And there is limited potential variations of alternative approaches which may be relevant in certain clinical scenarios. Critical analysis. The tips and tricks outlined in the pictorial essay proved to add valuable insights for both radiologists and trainees while performing ultrasound-guided musculoskeletal interventions. Assumed skill level, as essay assumes a certain level of expertise or familiarity with ultrasound-guided procedures, may not be applicable to all the readers, especially those who are less experienced or undergoing training. Incomplete coverage of the study does not encompasses the full spectrum of procedures relevant to general radiologists and trainees, potentially leaving gaps in the knowledge. Single modality approach. Other imaging modalities such as fluoroscopy or MRI, which may also be used in certain scenarios, are not discussed. Safety and risk discussion. While complications are mentioned for each procedure, there could be more comprehensive discussion on risk mitigation strategies and how to manage complication if they arise. Lack of level of evidence. Study does not specify the extent or quality of evidence supporting the described techniques, which may vary and affect their reliability and safety. Take-home message. The study aims to equip radiologists and trainees with the skills needed for effective procedure executions and patient care in musculoskeletal imaging. While becoming a teaching and bedside aid, it ensures the quality of healthcare provision. Characterized by anatomical location, procedures covers rostral to caudal end. The pictorial illustrations accompany text aids in the procedural understanding. The study overall boosts the comprehension and confidence in conducting ultrasound musculoskeletal for the radiologists and training seeking a career in the pain medicine. Thank you.
Okay, thank you, Dr. Khushboo. Now I think we go to the second presentation. This was an exhaustive presentation which covered most of the things, and over to you, Dr. Mahmood. Are you ready now?
Yes, sir.
Yeah, good. Khushboo, you can stop sharing. Yeah. Okay,
Sure,
Dr.
sir.
Mahmood has started. Okay, Dr. Mahmood, can you put your CV slide? I will just introduce. Just click on the screen once and then the arrow buttons will move. Yes. So Dr. Mahmoud Al-Jabri has done his MD from Jordan Medical Council. He's done his GMA anesthesiology and is the anesthesia specialist at Ibn Al-Taham Hospital. He's the head of department at JFMH. So he's currently the fellow in pain medicine at DYPU University in Navi Mumbai. So over to you, Dr. Mahmood.
Thank you, sir. Now we are going to talk about ultrasound-guided Bursa injections. Made this article by Kevin C. Bagel, Rina Patel, David Chen, and Nikki Okwilgo. The journal name is Skeletal Radiology. Introduction. The native bursa is a structure lined by synovium located adjacent to a joint, which may serve to decrease the friction between the tendons and overlying bones or skin. An adventitious bursa, which is non-native structure, which develops later in life secondary to abnormal stress and friction involving subcutaneous soft tissue. Inflammation of these extra-articular structures result in bursitis, which are usually treated either by conservatively with non-invasive treatment such as anti-inflammatory medications or physical therapy, or we go with invasive options such as percutaneous needle based on surgical interventions are considered. Aims and objectives. The aim of this literature to review core principles of musculoskeletal interventions involving selected bursa using ultrasound guidance. Materials. Pre-procedure evaluation and consent. Relevant imaging and medical history, including lab values, allergies, and current medications. Informed consent is required prior for any procedure. As for the Society of Interventional Radiology recommendations, screening anticoagulations laboratory value are not recommended for patients with minimal risk factors like in bursal injections, but for patients with higher risk, the INR should be corrected within the range of 2 to 3 or less with a platelet count less than 20. The timeout is always performed to confirm the correct patient procedure and site of, in addition to recommendations of prevalent allergies, medications, and any abnormal lab values. Medications choice. The medication of choice is steroids are frequently used to treat pain, and there is no consensus regarding the superiority of specific agents for bursal injections. Particulate steroids such as methylprednisolone, triamcinolone, and betamethasone have lower solubility and therefore last longer at the site of injection compared to non-particulates such as dexamethasone. Here is a table showing us the commonly used injectable steroid and local anesthetics. Steroids like methylprednisolone, triamcinolone, betamethasone, and dexamethasone. And for the local anesthetics, lidocaine, bupivacaine, and ropivacaine with different concentrations. Methodology. The technique focused on pre-procedure scanning, including grayscale and Doppler imaging, should be performed before every procedure because the pre-procedure ultrasound guided provides opportunity to choose the optimal approach and to assess for any additional pathologies. The majority of bursal injection can be performed with high frequency linear probe from 9 to 15 megahertz. But for huge people or large people or deep target, we may use a low frequency transducers. Then a 22 gauge or 25 gauge needle is sufficient, although for aspiration of potential viscous fluid, a larger gauge needle from 16 to 18 gauge is required.
I think Dr. Mahmoud, your connection is lost.
Recommended. Post-procedure guide injection
sorry,
site,
Dr. Mahmoud, can you hear me?
Post-procedure pain assessment is provided by the patient using. Yes, sir.
Yeah, in between we just lost you. So can you repeat your last line?
Which one? Post-procedure guidance.
Just before that.
Yes.
Yeah, post-procedure guidance. Yes.
Post-procedure guidance. Following the injection, a small bandage is placed over the injection site, and the patient is instructed to keep the area dry for at least 24 hours. And we have to inform that the patient that the steroid injection may take up to 7 days to reach its peak and full effect. And we ask the patient to monitor the pain scale closely over the next weeks. And the post-procedure pain assessment is provided by the patient using from 0 to 10 point scale with comparison to pre-procedure levels. The patient may also be asked to perform any provocative maneuvers or positions which exacerbate the pain to provide a functional assessment. Results and discussions. First, we will talk about the subacromial subdeltoid bursa. This bursa is the largest bursa in the body but it's thin in structure. It's composed of 2 separate bursa. The average thickness is no more than 2 millimeter. The SASD bursitis is often related to a subacromial impingement, but can also have other causes such as inflammatory arthritis, crystal deposition, or infection. Ultrasound evidence of SASD bursitis will appear like hypoequic intrabursal fluid, may be present in between hyperequic peribursal fat. The SASD bursa can be assessed through a lateral deltoid approach. Once the location is confirmed, a mixture of 40 mg triamcinolone or methylprednisolone and 2 ml of bupivacaine or ropivacaine should be injected. Here in the picture, which is on the right, we can see the patient's position should be in the upright sitting position or supine, and the arm abducted, neutral, or internally rotated. Then in the ultrasound image, we can see the needle piercing to from the deltoid till the peribursal fat, here, till the peribursal fat, and here is the long axis of the supraspinatus tendon, and here is the bursa, and there is the needle piercing the deltoid. And at the beginning, we inject a minimal amount till we see in this figure, we see the person swelling with the injectate, and then we continue injecting the triamcinolone and the local anesthetic. Scapulothoracic bursa. Scapulothoracic articulation is a complex pseudojoint created by the large flat scapula landing over the thorax without bone attachment. Two anatomic major bursa, including the infraserratus, which is the scapulothoracic, and supraserratus, which is the subscapularis bursa, in addition to 4 inconsistent adventitial minor bursa. The infraserratus bursa, located between the serratus anterior and chest wall, is the most common source for scapulothoracic bursitis, and therefore the primary target for steroid injections. Different etiologies for shoulder pain, repetitive overhead activity, snapping scapula syndrome, elastofibroma dorsi, osteochondroma, prior scapular or repifracture, or scoliosis, scapular dyskinesia, or altered biomechanics. Scapulothoracic bursa. Here in this figure, we can see the position of the patient. The patient is prone, and the symptomatic upper extremity in the chicken wing position. The arm is placed across the lower back, abducted with the elbow flexed. Widening this position is widening the scapulothoracic interval, and the ultrasound probe is then placed over the area of pain, typically along the medial inferior border of the scapula. If the patient developed respiratory symptoms during the or immediately following the injection, a follow-up chest radiography should be obtained to assess for pneumothorax. Here, we inject steroid injection have proven to be effective in treating scapulothoracic pain, and should be considered in patients with scapulothoracic bursitis and snapping the scapula. Injection is typically performed while prone with the symptomatic upper extremity in the chicken wing position. And in this figure, we see in figure A, we see the axial T2 fat saturated, and in T2, we see it post-contrast, the MRI, the shoulder with larger scapulothoracic bursal infusion, secondary to osteochondroma, ultrasound prior to aspiration. We see here in C the needle piercing the bursa, which is before aspiration, and in D, the post-aspiration, we see there is a change in the size of the bursa. And here we see the scapulothoracic bursa. In this image, we see the scapula, the rim of the scapula, and here we see the rib. This is before any aspiration or injection of the medication. And here we see the needle that's piercing toward the bursa, which is scapulothoracic bursa. And in this figure, we see after emptying the bursa of the fluid. And in this figure, we see there is the two kinds of bursa, which is the blue one, which is the scapulothoracic bursa, and here we see the subscapularis bursa, which is the orange one. Iliopsoas bursa. Iliopsoas is a muscle, is compound muscle composed of the psoas major, psoas minor, and iliacus muscle. The iliacus and psoas originated from the iliac fossa and vertebral bodies respectively, extending inferiorly toward the insertion of the psoas on the lesser trochanter of the femur, where it serves as the main flexor of the hip. The iliopsoas bursa, the largest bursa around the hip, is located deep to the myotendinous junction of the iliopsoas muscle, anterior to the hip capsule and lateral the femoral vessels. When related to the psoas tendon, iliopsoas bursa may be present secondary to tendinosis, which is commonly seen in the setting of overuse, acute trauma, or following total hip arthroplasty. Snapping hip syndrome, another cause of hip pain related to psoas tendon, is a condition where there is pain and an audible or perceived snapping of the hip with movement. In this figure, we see the position of the patient, which is supine, and the transducer is placed in transverse plane at the scapular brim. Iliopsoas tendon should be identified, which is medial and superficial to the joint. Here we can see the iliopsoas tendon, which should be identified, which is superficial. And in this figure, we see the vascularity, which is the artery and the vein, and underneath them, we see the bursa. And here, in this figure, we see with compression to differentiate between the vein and the bursa. With compression, we see the vein disappeared. And in this figure, we see the vein reappeared after removing the pressure. And in this one, we see the iliopsoas tendon sheath injection. Here is the fluoroscopic image of the right hip in a patient with a total hip arthroplasty during iliopsoas bursal injection. We see the move superiorly away from the needle and confirming the location of the thing within the iliopsoas bursa in this figure. And in this figure also we see the vein and artery and the bursa. Trochanteric bursa. The trochanteric, which is called also subgluteus maximus bursa, is deep to the gluteus maximus and tensor fasciolata at the level of the greater trochanter. The largest lateral hip bursa overlying the attachment of the gluteus medius and the gluteus maximus and vastus lateralis, lateral hip pain, whether related to gluteus medius minimus tendinopathy, trochanteric bursitis, or as part of the carpotage procedure to treat calcific tendinosis. The use of ultrasound guidance can improve outcomes of these injections by directly targeting only the trochanteric bursa. Greater trochanter bursa is typically seen as a thin echogenic line deep to the gluteus maximus tendon and iliotibial band, but superficial to the gluteus medius tendon attachment. Here we can see the position of the patient. The patient is placed in the contralateral decubitus position. The transducer is placed in the transverse plane at the greater trochanter, where both the gluteus medius and the minimus insertion are visualized at the lateral and the anterior facet. The needle is advanced posterior to anterior through the iliotibial band, and the patient is asked to internally rotate their hip. This is the sonographic image. Here we see the T2 fat saturated MRI of the hip, and it demonstrates edema-like signal in the greater trochanter bursa, which is between the gluteus maximus and gluteus medius, and about just superficial to the greater trochanter. And in this image, we see the ultrasound image. Here's the gluteus maximus and the gluteus medius, the greater trochanter, and there is the bursa, which is in between the gluteus maximus and the gluteus medius. And in this figure, we see the gluteus maximus medius and the needle piercing toward it reach the tip to the bursa, and either we aspirate or we inject with the 40 milligram triamcinolone with formal bupivacaine. Ischial bursa. The ischial bursa is located between the hamstring origin on the ischial tuberosity and the gluteus maximus in constant adventitial from prolonged sitting, cycling. This can present as buttock pain or even a buttock mass or as pain radiating down to lower leg, diagnosed after exclusion of other causes of pain at the buttock, such as calcium hydroxyapatite deposition or other masses, including myxoid tumor, schwannoma, or neurofibroma. Relatively rare condition. No studies specifically assessing clinical outcomes following ultrasound-guided steroid injection into ischial bursa. This is the position of the patient. In a prone position, the ultrasound probe is then used to define the hamstring muscles. The transducer is placed in transverse plane over the most lateral aspect of the ischial tuberosity, and the needle is directly toward the space between the ischial tuberosity and the gluteus maximus. Here we see the MRI image with the T2 fat saturated and T1 fat saturated post contrast, and we see the image demonstrates RM enhancing fluid. There is a fluid collecting adjacent to ischial tuberosity within the ischial bursa, which is consistent with ischial bursitis. The transverse ultrasound image of the different patients show the injection of echogenic steroid into the ischial tuberosity here, which is on the hamstring origin, and we see here is the bursa, and this is the needle after the aspiration of the bursa fluid. The Becker cyst or popliteal cyst. The popliteal cyst found between the medial head of the gastrocnemius and the semimembranous, also referred as a Becker cyst. Most common mass of the posterior knee and the common source of knee pain. Treatment of the cyst with image-guided intervention often yield positive results. Press the patient of the position of the patient, the prone position, and the transducer placed in transverse position with the 16 or 18 gauge needle advanced into the fluid collection, which is then aspirated. And in this image, we see the popliteal cyst aspiration. In this one, this is a T2 fat saturated image of the left knee with a separated popliteal cyst. The transverse ultrasound image of the posterior knee during popliteal cyst aspiration shows cyst extending toward the knee joint, and there is the needle, and it's piercing to the, and this is what the medial gastrocnemius and semimembranosus, and this is the bursa or the popliteal cyst, which is the needle piercing till it reach and for the aspiration. The conclusion, this review highlights a variety of bursal procedures which can be performed accurately with ultrasound guidance. The utility of ultrasound for bursal injections lies in its ability to provide precise needle localization in real time without significant safety concerns compared to other imaging modalities. Bursa may present as very thin, curved structures. Therefore, choosing the optimum approach is crucial to maximize the accuracy of needle placement and efficacy of the procedure. And awareness of the expected outcomes is important when communicating with patients and referring providers to optimum patient care. Limitations accepted. Allergic reactions due to use of steroid as an injector in bursal injections related to medication additives rather than the steroid itself. The majority of bursal injections can be performed with with a 9 to 15 megahertz linear transducer, a curved low frequency transducer may be useful for large patients and deeper targets. Ultrasound settings and patient's position affect the visualization of the target Bursa. Critical analysis. Steroid injection is superior to physiotherapy for decreasing pain and improving shoulder function 6 to 7 weeks following the procedure. USG parcel injection, more accurate than injections by palpation alone at certain anatomic sites. Scapulothoracic bursa is very thin and difficult to visualize, even when distended with a thin layer of hypoequic fluid. Not all bursa injections give the same outcome post-procedure. It varies from one to another. Contraindications for ultrasound-guided soft tissue injections may include prior allergic reaction and cellulitis or soft tissue infection at the injection site. Take-home message: ultrasound provides an opportunity for practitioners to both diagnose and treat a large variety of musculoskeletal conditions in one interaction, proven to be a useful tool for essentially all parcel injections or aspiration of the extremities. Steroid injections have proven to be effective in treating scapulothoracic pain and should be considered in patients with scapulothoracic bursitis and snapping scapula. Thank you.
Thank you, Dr. Mahmoud. In between, I think we lost you a couple of times, but then Zoom, I think it covered it up. So we didn't need to interrupt you. So thank you, both of you, for presentations. So now over to you, Dr. Aanchal and Dr. Navita, for any other comments. Thank you.
So I want to first, say best wishes to both the speakers. They really worked hard because these two papers, they had a lot of pictures, lot of explanations, and they have improved a lot from what we discussed in rehearsal. So great job.
Thank you, ma'am.
Yeah. So and the for the second paper, actually, the two bursa which they have discussed, like scapulothoracic, for example, the needle path, I think, should be more clearer because, you're really working close to the pleura. So when it looks simpler in the thing, but the scapula, when it comes, you really can't see the medial lateral half of the needle. So that's the one thing I found in the critical analysis. And Dr. Navita, ma'am, if you remember, we had a patient together. I think you remember your smile. We together had a patient. He was a student doing the IIT engineering. He had a buttock pain and all the MRI, everything was normal. And to the point that he has been to psychiatrist, and his father is at some very high position in police, like some IPS or so. Ma'am did the diagnostic skill bursa injection and some external rotator. And then you were planning to do PRP, but then his parents were staying in Delhi. So they came to me to get the procedure done. So I did 2 sittings, ma'am, and he's doing really well. I don't know if he came back to you.
No, he didn't. But if he's doing, no news is good news.
Yes. So his third time is I got I heard from his father's assistant that he's doing well. So he got the 2 shots. So that's one common patient of this same is external rotator ischial bursa / that kind of pain, and he was suffering a lot. He couldn't stand for his internship, but so I called her that, ma'am, what did you do in that exactly? And she told me, and the same sites we did the PRP injection. So this is the kind of, that when everyone is in diagnostic dilemma, what do you do? Like buttock pain, a lot of patients presents to that. So ischial bursitis is one of the very not so uncommon diagnoses that we think of. It should be kept in mind especially when the patient is complaining of lot of pain, but then you are not seeing anything in the relevant investigations. Even the soft tissue scans. And for the first paper, I want to mention for knee, like we do suprapatellar, below the quadriceps tendon injection here, but they have mentioned about the trochlear. So when from the place I trained in Chicago, this trochlear injection, the way they have explained, that was the normal for us. That's how I was trained to do the knee injections. Like in the OPD, the patient used to sit and just knee half flexed, and you just do the injection there. And they have given, if someone reads that paper, they have given certain tips for the positioning, because in ultrasound, positioning and knowing the anatomy is the key. So that is a very good paper if you want to learn, how to do it, how to, bring that view, bring that picture when you are actually, because half of the job is done when you have a good picture in view. Over to you, Navita ma'am.
Yeah, so thank you, Aanchal. And good kudos to both of you. You have done very good job.
Thank you, ma'am.
Critical analysis, Khushboo, it was amazing.
Thank you so much, ma'am. Thank you.
Mahmoud, I know it was, there were only 4 or 5 four Bursa, right, to discuss. So a good job done. I would add to this, yes, coming back to the patient, right? So all of those who are present here, see, we don't treat the MRI. I always tell my fellows, I always tell everyone that we don't treat the MRI, we treat the patient. And this patient, he had gone to, for so many years, he could not sit. He was standing and doing his job. And he is a student in IIT. And he was standing and he was, he couldn't find out what was the pain generator. He had been given an injection already, but then things didn't work for him. That is when, on the tender point, when we came to know that there was a little bit of fluid in the ischial bursa and internal rotators because of the bursa. See, when the pain is there for a longer period of time, then the central sensitization and the peripheral sensitization, they come into picture. And for him, that's why the central sensitization came into picture, and then he was referred to a psychiatrist. So identifying the pain generator is very important. Not looking at, if you get a trochanteric bursitis in ultrasound or in your MRI, go ahead and treat the bursitis, because mainly coming to the second paper, see, the trochanteric bursitis, they have given this because they are talking about bursa. But coming to clinically, it is not when the patient comes from the lateral thigh, upper quadrant of pain. It is called as greater trochanteric pain syndrome. And very, very uncommon, very less you see the bursa itself, that there is a Gmax bursa, and then it's a huge bursa, trochanteric bursa. So then it can be a Gmax bursitis, it can be G medius and G minimus bursitis. So these 3 include the whole trochanteric bursitis. And it's not the bursitis, it is a misnomer. It's the gluteal tendinopathy. So we have to see that when you are doing an ultrasound injection, then whether there is any fraying or the tendons are all, the fibers are there or not. This is what I want to add, because clinically, what we study and then what we see, we have to keep these things in our mind. Scapulothoracic, again, it is very difficult. The only tip here, what I can add, is that if you oblique rather than in a transverse view, if you oblique, then you'll be able to identify the fluid in a better way rather than in a transverse plane. So in the transducer, if you keep it a little bit oblique, as we do it in the intercostal nerve blocks or the paravertebral, so then you'll be able to identify the fluid in a better way with, again, a dynamic, as we do in a GH effusion. So if you do a dynamic maneuver with the chicken wing, so then if you do a dynamic maneuver, you'll be able to identify that the fluid is coming out and coming in and out. So that is what they could have used this. Otherwise, it's really good. There are so many things I need to add to. I know if we have time. So, but these are, I can see all are very enthused people who are sitting over here, and this will definitely help. When we talk about SASD bursitis, so there are some tips and tricks over here. So see, it is a 2 millimeter, as you have, Mahmoud, you have already discussed, you have told that it's a 2 millimeter thin rim. So when it is bursitis, when it is more than that, then it is a bursitis. you do a dynamic imaging, and if there's a fluid collection over here, so it's an SASD bursa, right, which is causing the pain. And if you have to do this injection, then in the first paper, they were doing it in cross-sectional view, in Khushboo's thing. And in Mahmood's paper, they are doing it in the longitudinal way, longitudinal section. So it's better if we do it in a longitudinal, because we can see where exactly the deltoid is, and you can actually guide your needle, and you can see where through the acromion it is going through the acromion. One more thing, when you are injecting into a bursa, you do not see the blab. You have to see it flowing up and down. You have to see the flow. Then only it is in the bursa, because it is a very small space. So when you go in a bursa, what you do, the trick over here is that you go with the bevel up. Once you reach in the bursa, you change your bevel down, right? The needle. Why we are doing this? Because supraspinatus tendon is there. We don't want any injury. We don't want any injury to the tendon. So if you don't want any injury, there will be no cutting injury, and you'll be injecting the fluid. And that will, you can see that the fluid, next time when you do a SASD bursitis, you can do, I know with the pain with the person who has SASD bursitis will not let you place his or her arm in the what we call as a modified cross position. That's the best position, but that's neutral position, it can be given. It's a little bit, it's not so easy. It's very difficult, because you have to be you have to sit in the lateral side beside the patient, and the machine has to be in front of you. So these two things I wanted to add in the second paper. But yes, there are many things. Time allows, Sidharth?
Yeah, of course, ma'am.
So coming to the barbotage, very nice. Coming to your paper, Khushboo. Barbotage, yes, very nicely 2-needle approach.
Yeah, ma'am.
Just want to add, we can do a 1-needle approach. First do in the middle of the calcific deposition. If it is hard, then only do it. Barbotage, very important. The indication is very important. So in the middle of it, because that is more easy to target. With an 18-gauge needle, do a barbotage, means you are fraying this calcium deposition, and then you can do it with a single needle also. Double needle is better, which is already being which is there in the paper. Hydrodilatation again, literature says 40 ml of normal saline, and here the authors have used 5 to 10 ml. I would agree with that. Yes, absolutely, because 40 ml of saline, gone are the days when we used to do the capsular rupture, because hydrodilatation means when you rupture it, and then that is where you get because after, even if you rupture, the pain, and the results of studies were done, the rupturing the capsule and non-rupturing the capsule. If you use a little quantity and do it early in adhesive capsulitis, the results are as good as not rupturing. So then if you are able to inject around 10 to 15 ml of saline, good enough, because it is very difficult. Even 20 ml, practically speaking, I would, Aanchal and Sidharth would agree with me when I say this. And one more thing, hydrodilatation, if you do it with the anterior rotator cuff interval approach, then you are getting good results. Why? Because there's a thickening of the coracohumeral ligament. So if you are going through that, you are already breaking the coracohumeral ligament thickening and the adhesion of that coracohumeral ligament. So that is what you can include in this along this when you are talking of tricks and this thing. The second thing, yeah, when you discussed about epicondylitis, the approach. So the right approach means if you just keep your hand abducted and the forearm is in extension and supination, so you might miss. So it's better to flex your arm and then put your one probe on the lateral epicondyle, and then let the other probe take the position of the common extensor. And when you're doing the common flexor, so then abduct it and externally rotate it. So keep the position of the arm, position of the probe at the medial epicondyle, and then trace it down. So that is a better, and always when you're using particulate steroid, give it in the sheath, do not give it in the tendon, which we all know. One thing I have fully released, the way was absolutely right, hip joint and knee joint, as Aanchal says, because these are radiologists, that is why they are going through the cartilage. But we have a less painful method of hip joint injection in the superolateral recess. If you remember the image which you had shown, they were going below the labrum. Don't go because you are going to cause more pain. Just come down, because in the superolateral recess at the junction of head and neck, there you inject your injected, because it is communicating with the hip joint. So why to go and then you are just needling and using a bigger gauge needle and then causing pain to the patient? Not required. The same thing with the knee joint. You can go for the lateral recess or the patellar recess, where you can the bursa, and you can, that is communicating with the knee joint, and then you can inject rather than going to the through the trochlear cartilage.
Ma'am, here internal rotation is not required the way like you are saying on this procedures. So because
not required, because in the hip you are saying, right? So the hip is now neutral or little bit of external rotation. Patient is in supine position. Trace the hip. There are two ways. You can trace it from the greater trochanter towards going to the medial, or trace the vessels and then come laterally and towards. There's an oblique angle, so that is more important. You have to identify the angulation of hip and the head and neck of the femur, because that is where, that is where you can.
They are saying because they want to move away the vessels, because they are going on the head.
Because they are going through, that is why, because they are going through this cartilage or labrum. So if you are going, then you are away from the vessels. The only vessel which comes in middle, you have to color your, you have to on your Doppler, and you have to see for the circumflex humeral artery. You don't have to go through and through it. So you have to just keep it away. Externally rotate, that is abduct, and that's it. A little bit of external rotation. Interstitial, the intermetatarsal bursitis is a part of Morton's neuroma, because then only you say that yes, there is some Morton's neuroma. There can be a bursitis plus or minus with the Morton's neuroma, not only with the metatarsalgia. And the only thing which I can suggest is that the probe, the position of the probe was on the plantar aspect. You can keep it on the dorsal aspect and then go through in-plane approach, which is again a very ergonomical approach for you. So you can keep the probe on the dorsal aspect of the foot and then go ahead and do
you feel more safer as well.
And safe. You will feel safe.
That's how we're used to doing it.
So if you keep the probe on the plant, just imagine keeping one probe on the plantar aspect and you're going above it. So how if you move, and 1 millimeter of movement is, you don't know where you are in the ultrasound. So if you have to be very stable, then keep the probe on the dorsal aspect, and you can go into an approach. It's very safe, and you are very stable. The stability is more. That's it from me. I think so. Too much from me, huh?
No, ma'am. Thank you for the valuable.
Thank you, ma'am.
Thank you.
So, Dr. Mahmood and Dr. Khushboo, if you have any questions or anything, just feel free to ask. Dr. Aanchal, any comments from you? Otherwise, we just end the session for today. We also have some questions from the social media. I'll just put them across.
No, sir. No question.
Okay, so yeah, please go on.
That someone is asking about more details about hip joint. I think so that Kritika, does it answer your question?
Yes, ma'am.
From whatever you discussed, that inferior approach would be better.
Yes.
And, that gave me that solved my doubt. And another for the paratenon hydrodissection, where what will be the clinical symptoms and how different it is from the Achilles tendinopathy or tendinitis, and what different symptom will be there for doing this bracing procedure. It was a new term for me.
Okay. So paratendon scraping is actually basically not when the patient comes to you with tendinoachilitis and there's a fluid around in the tendon, paratendon because it's not a synovial tendon. When there's a sheath is synovial, we always say it's a tenosynovitis. When there's a sheath is not synovial, then we always say it's a paratendon injection, paratenon. So tendinoachillis, we do paratenon injections because it's not synovial. So we do scraping only for me because the pulley scraping and the scraping of the tendinoachillis only when there's adhesions, scar adhesions after the surgery, or there's a chronic tendinopathy and you have done everything and it is even if not refractory to your injections, then this is where you do paratenon scraping. It is practiced a lot in Western countries, and for us, I would suggest that if the patient comes to you for the first time, go ahead for the steroid injection in the paratenon rather than doing the scraping. It is always better. You can do your PRPs if there is a tendinopathy, chronic tendinopathy. Go ahead and do after fenestration, do a PRP, dextrose injections, prolotherapy. I will definitely reserve this paratenon scraping only in few of the cases, that is where the adhesions, they are not getting better with all the other interventions. What do you say, Aanchal?
Yes, actually, if you're doing PRP, then it's at least you're safe, or if you're just doing saline and I think the hydrodissection, the good volume hydrodistension, is really works well if you're just injecting saline. And most of the studies, they haven't found big difference like it at supraspinatus. They have, it's big difference between PRP and saline. But Achilles is one of the space where they haven't found, too much significant differences when it comes to, if it's tear, then yes. But if it's just tendinopathy, then saline works good as well if you inject good volume in retrocalcaneal space.
I think so. They must have used, this might be a misnomer, what they have used in the paper, scraping. What they have described this technique, I think so it's more of an injection in the paratenon. Because what they have described is going above and below the tendon it's more of a injection rather than scraping. They've used this as scraping. This is according to my understanding. I think so.
So that is what it is. Yes.
Yeah,
right.
it is. Yeah. So it's not the scraping. It's not scraping per se, scraping of the tendon, paratenon. I think so. It's the injection, paratenon.
The injection only.
Yeah.
They have made the direction in such a way.
Yeah. The scraping they are saying.
That, yes. Yes. Okay, so there is a couple of questions from Facebook. Dr. Saida Shakira, she asks, ma'am, are long-standing bursae present with calcium deposits within the fluid? So I think that's true. So you can have calcium deposits. Then she also goes on. She is discussing a particular patient which she saw today having severe pain below the talofibular area, but proper bursa-like picture was missing. But I could see calcinosis with fluid collection around it. What can be the treatment? So she's describing a particular case where she says that there was a pain in talofibular area, but there was she could not identify a bursa as per the characteristics, but she could see some fluid correction around it and some calcinosis. That means I think she means she found spicules of calcium where they should not be there.
Talofibular.
Yes. Did she mention medial or lateral?
Which part? Which?
No, she's not mentioned.
And which bursa are we talking about? Because then there is a.
Yeah, she's not specific. Actually, I think she's not clear about the anatomy, and probably she's try to describe something which she's seen.
Maybe you can send us the history and your findings and along with the pictures. And maybe we'll be able to,
So,
because talofibular, if it's lateral, it could be peroneal tenosynovitis. If it's medial, then more like a tibial area, or even medial or lateral plantar or tarsal tunnel.
So yeah, she's replied. She said lateral malleolus. Okay, so
Lateral malleolus.
yeah. So that is lateral.
Okay.
So then lateral malleolus, we don't see the either you are talking about the talofibular ligament, and where in the lateral malleolus, then it means that you are talking about calcaneus, somewhat about
Clear,
So it
then
cannot be.
MRI scan would be helpful
ATFL.
because it sounds more like a peroneal tenosynovitis. The
Maybe peroneal, or if it is below down, then the ligaments. Then you have to send all the pictures, or be more descriptive.
Yeah, so Dr. Saida, I'll suggest that you just find out a couple of things. One is try to be more clear about the anatomy, where you are, and then what structures you're talking about. Then try to find out what causes this pain. And bursa are not everywhere. Like any fluid collection, we cannot label it as bursa. Yes, she's saying that she'll send the pictures.
Yeah.
So sure. Just mail us the pictures. You can just mail me on mumbaiPainSchool@gmail.com, and we'll just give you some comments. Great. So I think we end it here. Thank you all of you for the kind all the discussions and all the comments and all the beautiful presentations and all the great clinical experience. Especially, we're very happy to see both of you collaborating for a patient. I mean, that's something which we greatly fathom. And thank you for sparing your time. So now I'll just go to the last part of the presentation, where we just discuss about the future options. So again, thank you very much. Thank you, Dr. Navita. Thank you, Dr. Aanchal, and thank you all of you for being there. So this was the season 4 of Mumbai Pain School's Pain Journal Club. This season we are focusing on MSK Ultrasound, and we had a new time, that's 8 p.m. and we grouped some topics for this season, and we focused on, this time we had 2 faculties, 2 papers, which we found was a more suitable format. The next steps for you, those of you are here for the first time, just join our mailing list. We have a WhatsApp group. Just join the link in the chat, and suggestion, comments are welcome. Just mail me on mumbaiPainSchool@gmail.com. And the next one, do join us for the next one on February 23 at 8 p.m. And those of you are looking for some workshop, so stay tuned for this 26 to 28 April workshop, which is coming soon. So thank you all. See you soon next week, same time. Until then, bye-bye.
Thank you. Good night, everyone.